PowerPoint presentation was made to present my scientific article to obtain the DO diploma at the International Academy of Osteopathy. The title of the scientific article is The Neurovascular Effect on the Lower Extremity After Spinal Manipulation of the Thoracolumbar Junction T12L1. My name is JonChristensen. The background of the study is that during daily activity, the lumbar spine provides mobility and mechanical advantage due to the numbers of facet joints. Somatic dysfunction or restriction are a common condition found by osteopathic examination. A somatic dysfunction is a unique osteopathic concept. But what is the definition? The definition was made by the Educational Council of Osteopathy in 1981. Some diagnostic criteria are found by palpation and should be present. First, tissue changement, asymmetry, decreased range of motion, and tenderness. All this known as TART, and any of these conditions must be present before the diagnosis as somatic dysfunction can be present. A somatic dysfunction affects the capsule receptors 1 and 2. This is consequently reducing the inhibition of the segment by the 2 and 3A fibers. This reduced inhibition of the segment results in an increased activity of the somatic motor gamma neuron and the sympathetic or parasympathetic neuron depending on the level of the somatic dysfunction. But how to treat a somatic dysfunction? Osteopathic manual treatment are used as treatment. Especially high velocity, low amplitude thrust is used when a somatic dysfunction of type 2 is present. This type of manipulation uses a high velocity amplitude or thrust over a very short amplitude. It is usually associated with an audible crack. This manipulation reduces the activity in the capsule receptors and normalizes the inhibition of the segment, reducing activity in the somatic motor gamma neuron and the sympathetic or parasympathetic neuron. The benefit of this manipulation is an immediately reflexogenetic effect which is causing a release of the entrapped folds or plicae, a relaxation of the muscle which is hypertone, and immediately vasodilatation. The aim of an osteopathic manipulation is to restore joint movement, normalization of the muscle spasm, stretching of the capsule ligamentous retraction, increases vascularization. All this is done to improve the body function to create homeostasis. This means that osteopathic treatment recognizes the enormous importance of the circulatory supply in an area of complaint, also known as the arterial rule. If the arterial, venous, lymphatic, and intestinal circulation functions better in a region of complaint, then the region will improve and repair faster, which is causing a faster autocorrection. But how can manipulation affect the vascularization? It is because the different type of receptors involved in the regulation of the vascular system makes it possible to affect the vascularization through manipulative treatment. The smooth muscles of the arteries is innervated by the autonomic nervous system, mainly the sympathetic nervous system. The sympathetic nervous system innervates the smooth muscles via the alpha 1, alpha 2, and beta 2 receptors. The alpha 1 and alpha 2 receptors is caused vasoconstriction, while the beta 2 causes vasodilatation. Also, parasympathetic innervation of the smooth muscles is through the mesenteric receptors M3, which causes vasodilatation. The arteries of the skeletal muscles are primarily innervated by the sympathetic nervous system via the beta 2 receptors, while the arteries of the skin are primarily innervated via the alpha. It is known that the sympathetic nervous supply to the arteries supplying the upper extremities comes from the segment C8 to T1, and to the lower extremity is from T12 to L1, also known as the thoracolumbar junction. Earlier scientific studies have shown that the relationship between manipulative treatment and the autonomic nervous system is present. It has been acknowledged for a long time, but only recent studies have demonstrated that spinal manipulation can affect the autonomic nervous system. Another studies has found a significant correlation between decreased pulse force velocity of the femoral artery and increased sympathetic nervous activity due to stiffness of the arterial wall. Another study measured a significant increased peripheral blood flow after operation in the sympathetic nervous system. But what was the objective of this study? The aim was to investigate the effect of high velocity, low amplitude thrust on the thoracolumbar junction in relationship to the vascularization of the lower extremities. A hypothesis was made. It was hypothesized that high velocity, low amplitude thrust on the thoracolumbar junction will increase the vascularization in the lower extremities. But how to investigate this hypothesis is described in material and methods. First, a study design. This study was carried out as a controlled, quantitative, quasi-experimental design. It was done by examination and pre-testing, intervention, and last, a post-testing. Some ethics was kept during the study. The ethic guidelines from the Declaration of Helsinki was kept during the study. A written and verbal information was passed on to the subject, and at any time, these subjects could withdraw without any questions. The subject's integrity was respected at all times. A written consent was declared. All test results and personal data was handled with great anonymously and confidentially. Last, this scientific article was approved by the Ethical Committee at the International Academy of Osteopathy. Now to the subjects. In total, 40 subjects participated, 16 females and 24 males. A mean age of 29.3, ranging from 19 years to 40 years. The inclusion criteria to participating of this study was asymptomatic or asymptomatic monolithical block of the thoracolumbar junction, male or female from age 18 to 40 years. The exclusion criteria to this study was cardiovascular disease, neuropathy or diabetes, female with pregnancy, radiating symptoms, for instance disc hernia or protrusion, subjects with contraindication to manipulation, and cancer. Now to the randomization. All the subjects were randomized into two groups, either intervention group or control group. It was done by every subject drew a colored card from an envelope, a blue or a green card. If the subject drew a blue card, they were in the intervention group, and a green card, they were in the control group. This study was carried out as a single-blinded study. Before participation in the study, all subjects were examined by an experienced osteopath. An analysis was made to cover potential exclusion criteria. Safety tests were performed previously to participation. Palpation, compression, percussion, traction, and osteoporosis test. In general, consideration was taken to the general safety and the general health and condition of the participant was evaluated. Subjects were examined to detect monolithical blocks or somatic dysfunction. It was done by oscillation test in sitting position. The vertebrae with increased resistance were tested further with a flexion extension test and a side bending test. This was done to investigate the mobility, if it followed the second law of Rayet. All included subjects in this study had a monolithical block in flexion or extension of the 12th thoracic vertebra or the first lumbar vertebra. The intervention. The intervention was done by a Nelson technique on the thoracolumbar junction. It was performed by a roll towel was placed at the processus spinosus of the vertebra with a monolithical block. If it was a lesion in flexion, if it was a lesion in extension, the towel was placed one vertebra below. Axial traction was applied to the arms, and a high velocity, low amplitude thrust were performed via the spine through the sternum in an anterior superior direction. This was done to the intervention group. The control group where the subject lifted by the elbows as in the Nelson technique, but without a thrust and without applying pressure to the spine. But how to measure the outcome? The vascularization is usually measured by laser Doppler flowmetry, Doppler ultrasound, and or transcutaneous oximetry. A significant correlation has been found between laser Doppler flowmetry and perfusion inject mixers by an oximeter. An oximeter is used in this study. It is a non-invasive measuring device with a probe which is placed on a finger or toe. Infrared light is used to estimate the underlying arterial hemoglobin oxygen saturation and changes in the sympathetic nervous tone affecting smooth muscle tone, thereby altering level of perfusion. Perfusion index is relative assessment of the vascularization comparing the pulsate components and the non-pulsate components of the signal. It is independent of heart rate and saturation level. In this study, the subject had the PI of the first toe measured in supine position. They were told to lie completely still in a quiet room with no external stimuli. The perfusion index were measured for 8 minutes, recording every 30 seconds. The subject lay still for 1 minute before and after intervention. It was repeated after the intervention. The statistical analyses were done by an analyst who knew about the allocation but were neutral whether the results support the hypothesis or not. All data was collected and stored in Microsoft Excel, and the analyses were done by a special program. All the continuous variables were found normal distributed, tested with Sharper-Wilks test. A two-sided independent t-test was used to compare the means of the two groups, while a chi-square test was used to analyze the non-parametric variables. Significant level of this study was set to alpha 0.05 for all statistical analyses. The results of this study. In total, 40 subjects were randomized in either intervention group or control group with 20 in each group. The two group was considered statistically similar at baseline. There were no significant differences found in terms of age, gender, weight, height, body mass index, type of lesion, or perfusion index. This is presented in Table 2. Figure. The results of the subjects before and after intervention is presented in Figure 2, where you can see the test group and control group 8 minutes lying still before intervention and 8 minutes after intervention. Written in words, the intervention group had a significant total mean increase of 0.74 in the lower extremity compared to the control group. The intervention group also had a PI at 4.07 before intervention and 4.90 after intervention, with a mean increase of 0.83. The control group had a perfusion index at 3.94 before intervention and 4.03 after intervention, with a mean increase of 0.09. This means that this study proved that a high velocity, low amplitude thrust on the thoracolumbar junction increases the vascularization in the lower extremities, because the intervention group had a total increase of 0.74 in the lower extremity